This is Walter Kemp. This is Hypertension Part 2. This is outside Glacier National Park. It's just one of the rivers when you drive into the park. So better than this. So this is Hypertension Part 2. Once again, there are me and Dr. Hughes' websites for questions. There are quite a few on them. I probably think there's 500 or 600 between the two sites. And then my Twitter, which like I said, I'll probably start doing that again maybe this week, next week. And then I'm a forensic pathologist, but I have a really strong interest in general pathology, organ pathology, and just in teaching medical students. Here are my disclaimers. Please read these. If these apply to you, then please do not watch the videos. Do not watch the videos. If they don't, please watch them. I just want to teach people pathology. Here's the third disclaimer. Same thing. Read that. And like I said, if you want to understand about my teaching, just watch my introductory presentation, even though only a couple people have. But it kind of explains my theory on teaching and stuff like that, so you understand why I'm doing what I'm doing, if you want. Here are my list of references. I haven't mentioned these a lot, but these are all great books. I mean, these are all fantastic. Bakerman's we used when we were in medical school. If you can copy of this, Make It Stick is the one I frequently talk about, the reflection. The Clinician's Guide to Laboratory Medicine, great book. You can find it on eBay and stuff like that, but it goes through like laboratory testing, steps to take, everything like that. Of course, Robbins, I just like basic pathology. And then Dr. Stern's book, fantastic book. I wish they had one like that. When I was in medical school, basically guiding you from symptom to diagnosis. Great for going into your third and fourth years, and I think for testing and stuff like that too. So as usual, start out with a question. So pause, look at it, see if you can figure out the answer, and then go on to it. And then as you listen, it makes you key into the lecture and stuff like that, and it's shown to increase retention. And we'll talk about it at the end. So this lecture is basically going to be the pathologic changes of hypertension. So these are some that you see. Cardiac hypertrophy. Obviously, if the blood pressure is higher, the left side of the heart's doing more work, and it's going to thicken. And it's a concentric hypertrophy. Whereas an eccentric hypertrophy is what you see with volume overload. So somebody with aortic regurgitation, more volume coming into the left ventricle is going to cause an eccentric hypertrophy. But both of them will make the heart bigger. Just with hypertrophy, concentric hypertrophy, like with hypertension, you get not only a bigger heart, but usually thickening of the wall. Whereas eccentric hypertrophy, you get a bigger heart, but the wall usually stays relatively normal thickness, actually. Hypertension is a major contributor to atherosclerosis, and the atherosclerosis are at risk for cerebral infarcts, myocardial infarcts, contributes to abdominal aortic aneurysms. That arteriolosclerosis that we talked before, this leads to kidney failure and hypertension along with diabetes. As far as I know, with two main causes of kidney failure: aortic dissection, intracerebral hemorrhage in the brain, and then changes in the eye as well. And then to the right of it, what I did was I broke these into what are acute and what are chronic. So chronic are ones that would develop over time. So cardiac hypertrophy obviously doesn't develop overnight. It takes a while for the heart to enlarge, and then for them to get to the point where they're past hypertrophy into failure of the organ. Chronic renal failure, once again, is going to take a while to develop, and atherosclerosis takes a while. But acute changes happen relatively quickly. Aortic dissection, intracerebral hemorrhage, hypertensive urgency or hypertensive crises happen really quickly and need to be treated right away. So the actual underlying disease process, the hypertension may have been present for a while, but the acute event happens relatively quickly. Okay, so then the aortic dissection. What an aortic dissection is basically a tearing of the wall of the aorta. So basically a leak occurs, blood goes in through the intima, tracks along the media, and then the repercussions are going to depend upon what happens. So it can actually tear back in the intima, and then you get like a double-barreled aorta, which a person can easily survive. It can also tear out through the adventitia into the pericardial sac. It can tear out into the pleural cavity. And so depending on where it is, like obviously if it goes in the pericardial sac, that's going to have a much more likely to cause their death, because you don't have to get too much blood in the pericardial sac before you get cardiac tamponade, a couple 100 milliliters, whereas bleeding in the pleural cavity would be, a liter or two. Main cause from aortic dissection is hypertension. And that. So I showed top left is basically the aorta has been opened up, and the yellow arrows, you can see that dark black kind of line almost. That's the blood in the wall of the aorta. And then to the bottom right, that's cystic medial degeneration, which is an underlying risk factor for it. You can see it's just in people who have hypertension. You can also see it in people with Marfan syndrome. I've seen people with Marfan syndrome look at the aorta and there's just tons of this. So it's actually used to be called cystic medial necrosis, but it's actually not necrosis. So cystic, you can see little cyst-like spaces filled with that blue stuff. Medial, it's in the media, and then degeneration, it's basically breaking down. It's not looking the way it should. So another one, aortic dissection. The one to the left, the white arrow shows where the tear is. To the right of it shows kind of, you can see from the side. So the black arrow shows the intima, and then you can see that thin line of blood going there. So what it does is it dissects through the wall of the aorta in the media. And so, like I said, as long as that's what's occurring, the person will be okay. It's when it breaks out through the adventitia that the major problems occur. Two others, the bottom right, you can see, so the star shows the aortic valve. So the dissection went down to the aortic valve. So what's interesting about this is it usually causes regurgitation. You would think, well, it looks like it's going to block it and cause stenosis, but it doesn't. It basically upsets the annulus and causes insufficiency. And so it's in Robbins like that. And then I tried to look up and find something more detailed, went through a whole search like that, and I just couldn't find anything better than that description. To the top left shows the number, the ruler is actually sitting on the heart. So this is a dissection that went down to same general location. So basically what the yellow arrow shows the inner surface of the intima, the white arrow shows the adventitia, and the star shows where the hemorrhage is between them. So basically it's splitting the wall of the aorta there. There's not a lot of blood there, but it's dissecting. It's splitting open that media. Intracerebral hemorrhage is another acute event. Here you can see hemorrhage. It's very commonly centered on either the basal ganglia region, the cerebellum, or the brain stem. And those are the common locations for it. And what happens is they get these little microaneurysms called Charcot-Bouchard aneurysms. I think they're like 300 micrometers is what they say. So microscopic, that ruptures and they bleed. So this would be another acute complication of hypertension. So moving into the chronic ones, cardiac hypertrophy. So remember, concentric again. So you're going to get increased weight of the heart and thickening of the wall. The one at the bottom right, I show it, you don't see a left ventricle in there. Now, that's not necessarily represent what the patient has, because actually, as a forensic pathologist, my understanding is rigor mortis affects the heart too, which it probably should. And so the actual is very difficult for us to get an estimate on the chamber diameter and stuff like that. But I thought this was just really good for representation of that thickening of the wall. So what you see is there's really no symptoms of it. You can see signs, a sustained apical impulse. You can get an S4 when it contracts, when the atrium contracts and pumps blood in, it hits that kind of stiff ventricle, and then you get the S4. And then the big thing is they're predisposed to cardiac dysrhythmia. So a common cause of death I see at autopsy is people who have cardiac hypertrophy. Usually when a person has a heart rate of 500 grams or more, with normal being about 250, 300, somewhere in there, I will use that as a cause of death if I've ruled everything else out. But they are at greater risk. If you just PubMed it, you'll find and see that there is an increased risk. So the bottom right just shows kind of the same thing, a very thick left ventricular wall. The top left, sorry, I put him in the Valentine position and not the actual anatomic position. But the left of it is a markedly hypertrophied heart compared to a relatively normal-sized heart, just for comparison, and so you can see how big that can get. And it's usually going to be a left ventricular concentric hypertrophy because the left ventricle is what's pumping against that high blood pressure, against that afterload, and it's going to hypertrophy the left ventricle. Okay, this is actually in Montana. This is Beartooth Highway. This is a road basically between Billings to Red Lodge, up through here, and you can get to the park this way. You can also get to Wyoming, Cody, Wyoming. That very, very beautiful scenic drive. I highly recommend, if anybody is in Montana and in the area, to take this drive. Just make sure the driver's paying attention to the road and not the scenery, but very beautiful drive. Okay, so as I said, hypertension is one of the main modifiable contributors to atherosclerosis, and then we've talked about quite a bit arteriolosclerosis, and both hyaline or hyperplastic associated with malignant hypertension, so that developing higher blood pressure, becoming symptomatic within maybe a couple years or quicker, whereas hyaline arteriosclerosis usually associated more with the benign hypertension, the more decades-long one. The top right is the hyaline, the bottom right is the hyperplastic for comparison. So you can see that thick thick, acellular, no cells in it, eosinophilic thickening at the top, and then that concentric onion skinning with basically cells in there, so like layers at the bottom. And then the arterial sclerosis, by the way, that's what contributes to the renal failure. And so my way of looking at it is you have this thickening of the arterial. It's going to basically affect blood flow to some degree, is my thought of it, and it leads to basically tiny little infarcts, is my way of looking at it. So in the cortex, you will see tubular atrophy, which is the bottom right. So normally in the kidney cortex, you should see tubules back to back to back to back. So when you see space in between them, they're atrophic, and this is something we would see in people with chronic renal failure associated with hypertension. So it's very common, like I said, 25 to 30% of cases are due to hypertension. And my understanding is basically most cases of chronic renal failure associated with hypertension or diabetes. And then chronic renal failure affects basically every organ system. And basically what you see lab-wise is a decreased glomerular filtration rate. So here's the question. So pause, and then we'll go through the answer. A 57-year-old male with a history of hypertension is golfing with his friends when he suddenly develops a sharp pain in his chest, which radiates to his back. He is rushed to the emergency room by his friends. Upon physical examination of the following, what is most likely to be detected? So he's having an aortic dissection. Aortic dissections are known for having sharp chest pain, can radiate to the back, can radiate to other areas. I remember in medical school when the internal medicine attendings were saying it can radiate even into the groin, other places. And so you can imagine if the aorta is tearing, you can think of this sharp pain. And so what happens is they'll get actually asymmetric pulse in the upper extremities as possible, because what can happen is the dissection can occur after the right subclavian comes off, but before the left subclavian comes off. And so the right subclavian is getting regular flow of blood, whereas the left subclavian is affected by the dissection, so you get asymmetric pulses. Whereas all of them should be affecting the lower extremities because the dissections would affect it before it gets into the lower extremity. Okay? And then reflection, once again, go back, if you would, and think of, okay, what are 5 things I learned from this lecture? I'm hoping you learned 5. And then this, like I said, this really helps you kind of cement that material and everything like that. And like I said, I'm not going to give you a summary because that just allows you to go on to that and not think on this great way of doing it. Like I said, it's in Make It Stick. They very much praise this and showed a medical student went from the bottom of the class, top of the class, using this one technique. So this is actually not Montana. This is Scotland. There are just a whole bunch of locks and everything like that. And this one, that was kind of neat. There's one that has kind of like the heather and stuff like through it and everything like that. So anyway, just a little Scotland in the lecture. I hope this has been useful, and thank you.